fertilize an egg to cause an embryo to start to grow. Now, interestingly, like I said, we find that there are so many men that have male factor infertility in the union. So there could be low sperm count, that is called oligospermia. There could be abnormal motility, which is the sperms are there, a lot of them, normal adequate sperm in millions, but they are not really moving. We say they are astenospermia, which means they are slow. We have those that are abnormal in shape, because the normal sperm is supposed to have the oval shape and then the acrosome to attach to the egg to fertilize it. Some will not have the acrosome, some will have round head, some will have curtains, just a whole lot of differences in abnormality of the structure of the sperm. So we'll say that the sperm has poor or sometimes zero morphology, and that is the teratospermia, which means the sperm is there, they're actually swimming adequately, but they are mostly abnormal, and this will also lead to the delay. And so that's for the male part. And then we have a few men who do not even have sperm cells at all. So they have normal intercourse, they have the ejaculate, but when you look in the semen, there's no sperm cell at all. So I also find that a lot of men assume that when they have an ejaculate, it means that they have sperm. But that's not the case. The sperm cells are actually microscopic. They cannot be seen with the naked eyes. So having an ejaculate doesn't exactly mean the same thing as having a sperm and the capacity to get the wife pregnant. So on the part of the woman, we have some women that have very thick mucus clogs in their cervix. So even though their womb is normal, even though their fallopian tube seems to be normal, even though they are ovulating regularly, the mucus plug is so thick that the sperm cell is unable to swim through their cervix to go to the fallopian tube to access the eggs. So this is usually mostly just seen during assessment, during a cervical examination, and these women will usually benefit from insemination. So there are also some women who have fibroids that are growing inside of their cavity. Some people have fibroids within the muscle of the uterus, the intramural type. That will not stop a lot of women from getting pregnant unless they are very big. And then some people have it completely outside of the uterus, which is the subserous type. Those ones are completely ignored unless they are also very, very big and cause the woman to bleed or cause her to have pain, which is now a factor of the quality of her life and not necessarily for infertility purposes. But the fibroids are of concern to a gynecologist or to a fertility physician, as you may, will be those ones that are exactly inside of the cavity that could prevent an embryo from implanting. Then so some women will also have scar tissue in their uterus, either for previous instrumentation or previous surgery, like removal of fibroids. So all those are categorized under uterine factor of the weight. And then sometimes we have some women who have blocked or swollen fallopian tubes. So the uterus is fine, the womb is fine, just that the sperm is unable to go through the fallopian tube to go fertilize the egg, or after it fertilizes it, some will now be stuck within the fallopian tube, which is what results in some women having ectopic pregnancy. So we have tubal factors of the weight, and then we have ovarian factors of the weight. So ovarian factors are actually very diverse. So some women they are fully they have eggs, and they are young and they are viable eggs, but they are not ovulating. So some women will have anovulatory cycles. Some women, unfortunately, very young, but yet they have suffered what we call premature ovarian failure, where their ovaries just get to fail, even though they are still very young and they are within their best reproductive age. And then, of course, we have the older women who are suffering from ovarian exhaustion. So just go over it again. So the factors that will cause the weight, there's ovarian, which has to do with egg release quality and regularity or frequency of the release. We have the tubal, which has to do with the pathway for which the egg and the sperm would meet, whether or not it's blocked or is hostile, or the cells, cilia cells that line it, are no longer functioning to carry the embryo after the egg has fertilized after the sperm has fertilized the egg, to carry the embryo into the uterus where it should implant and be able to grow, sustain for 9 months, and then we have a live birth of a live fetus. And then we also have uterine factors where there's something wrong with the womb, and so even though there's good ovulation, there's good fertilization, but we are not having the embryos implanted in the uterus, and therefore we are not having a pregnancy. And then we also have cervical factor, which is usually not really common but easily treatable. And then we have the male factor. Now, just to quickly say that, unfortunately, because for years and years and years on end, the male were not going to the clinics, and so they were not really getting tested. There's a lot more options to treat a woman than to treat a man. So male infertility seems to be more difficult to manage at the moment. Treatment options are far less than what we have for the woman, and it's just a simple reason. For years on end, we've had gynecologists. In fact, the cesarean section was named so because Julius Caesar, the Roman emperor conqueror, was actually delivered by C-section, where his mother had been in labor and was going to die, and somebody broke a bottle and did stab the woman and brought out the baby. So they started naming it the cesarean section because that's how Julius Caesar was born. So there's always been gynecologists from time immemorial, and because of that, a lot of study on women health, reproductive health, how to better the chances of fertility in women. But now there are some group of urologists that have now formed an association. They call themselves andrologists, and they are focusing on studying while some men are having difficulties and having sperm issues and having some fertility issues. And I know that very soon we're going to have a lot more answers in that department than we currently have. It's been awesome speaking here. I look forward to the Q&A later. And I thank you for the awesome opportunity. Just to say a big thank you to the convener. I met her once, just knowing how I used to love her. She's soft-spoken, well expressive of herself, and super, super loving. Thank you, ma, for the opportunity to speak to your house. I do not take the privilege for granted. I look forward to coming back at 8:35 to answer questions. Thank you very much.
Wow.